rather recent studies when we follow patients of using the gold standard treatment or the gold standard treatment before the novel agents came in, and that was fludarabine, cyclophosphamide, and a CD20 antibody. And from these studies, when patients are relapsing, we see that they have the high-risk genomic aberrations like TP53, ATM, Notch1, and then there were a number of aberrations, in particular, that surprised me at least. We found in a study where we did whole exome sequencing before the patients received FCR and at relapse. And then we saw a proportion of patients that had mutations in a ribosomal gene. And so how could that be involved in CLL development? And we know from other studies, and this is a rather new area of ribosomopathies, where mutations in components of the ribosome that translate mRNA into protein also can cause disease. And there is a recent Spanish study that showed that this type of mutations that we see in CLL patients affect the ribosome fidelity, how well or how the mRNA is translated into protein. But this is, I think it's it's a totally new area, and so I think that this is one type of new knowledge from using next generation sequencing. But then we have also the novel targeted therapy and the B-cell receptor inhibitors and also BCL2 inhibitors. And from this, now when we have followed the patients somewhat longer, we know that the patients can have BTK mutations in the binding pocket where ibrutinib binds to BTK. That is a C481S mutation, the classical one. That so if at our institute, if a patient progresses or doesn't respond to therapy, then we sequence BTK to see if they have gained such a mutation. Another downstream component of BTK is PCL gamma 2 that can also be mutated, but usually most patients have BTK mutations, and some have also PCL gamma 2 mutation. And then for other novel targeted therapies, it's starting to come data on resistance mechanism.